Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 166 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, SPP, is a 57-year-old female patient treated with tenofovir disoproxil fumarate and emtricitabine with darunavir boosted with ritonavir. She has been virologically controlled since therapy initiation 36 months ago. SPP's estimated GFR has gradually decreased over time, and she now has evidence of proteinuria. She has a past medical history significant for arthritis and hypertension. Her NRTI backbone is changed today from tenofovir disoproxil fumarate and emtricitabine to tenofovir alafenamide and emtricitabine. So my question to you is, which best describes the expected clinical outcomes with the change? Is it A. Stabilization of renal function and bone mineral density abbreviated as BMD, or stabilization of renal function and improvement in BMD, or C. Stabilization of renal function and improvement in proteinuria, or is it D. Improvement in estimated GFR and proteinuria? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Improvement in estimated GFR and proteinuria. In switch studies from regimens containing emtricitabine and tenofovir disoproxil fumarate to emtricitabine and tenofovir alafenamide, several positive outcomes occurred at 48 weeks. Regarding renal outcomes, estimated GFR increased, and proteinuria decreased significantly, especially urinary markers of renal tubulopathy. That makes answer D correct. These changes were evident as early as 2 weeks after the change. Patients changed to the tenofovir alafenamide regimen also had increased BMD in hip and spine compared with further declines in BMD in those taking tenofovir disoproxil fumarate containing regimens. An increase in BMD is significant because reductions in BMD occur with most ART regimens during the first 6 to 12 months after initiating therapy, with the greatest changes associated with tenofovir disoproxil fumarate regimens. Improvement in the estimated GFR is expected, not stabilization. That makes answers B, C, and A incorrect. Improvement in BMD is expected, not stabilization, which makes answer A incorrect. Please advance to the next question. And the next question reads, RTJ, a 48-year-old male patient has been treated for HIV infection for 24 years. He has been virologically controlled for the past 8 years on atazanavir boosted with ritonavir and abacavir plus lamivudine. RTJ's TG have gradually worsened over time, despite diet and exercise, and secondary causes have been ruled out. So my question to you is, which of the following would be the best highly active antiretroviral therapy, HAART substitution strategy to address RTJ's hypertriglyceridemia? Would it be A. Switch atazanavir boosted with ritonavir to atazanavir boosted with cobicistat, or B. Switch atazanavir boosted with ritonavir to dolutegravir, or C. Switch atazanavir boosted with ritonavir to efavirenz, or would it be D. Switch abacavir to tenofovir alafenamide? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Switch atazanavir boosted with ritonavir to dolutegravir. Abacavir does not contribute to hypertriglyceridemia. That makes answer D incorrect. Tenofovir alafenamide may slightly increase Tg concentrations, but the increase is not considered clinically significant. Ritonavir-boosted regimens are likely to increase Tg and are the most likely cause of hypertriglyceridemia in this patient's regimen. Cobicistat atazanavir regimens have not varied significantly from atazanavir boosted with ritonavir regimens in the development of hypertriglyceridemia. That makes answer incorrect. Efavirenz may increase Tg, that makes answer C incorrect. However, dolutegravir does not appear to have cholesterol effects. That makes answer B correct. Please advance to the next question. And the next question reads, C.R.S., a 55-year-old HIV seropositive male patient has been admitted to the hospital for treatment of a deep venous thrombosis. His current HAART regimen consists of tenofovir alafenamide plus emtricitabine plus rilpivirine. C.R.S. regularly takes rivaroxaban, ferrous sulfate, hydrochlorothiazide and amlodipine for the management of other comorbidities. So my question to you is, which of the following would be the best administration of his ART regimen? Would it be A. Administer at bedtime, or B. Separate from ferrous sulfate by 2 hours, or C. Administer with a meal, or would it be D. Administer on an empty stomach? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Administer with a meal. Tenofovir alafenamide and emtricitabine do not have food requirements. Rilpivirine, however, has 40% reduced absorption when taken on an empty stomach compared with a meal consisting of at least 400 to 600 calories. That makes answer D incorrect and answer C correct. There are no drug-drug interactions with cations with this regimen. That makes answer B incorrect. Drowsiness is not a concern and may be scheduled at any time, which makes answer A incorrect. Please proceed to the next question. And the next question reads, P.D.M., a 62-year-old HIV-positive male patient is admitted to the hospital with an acute ST segment elevation myocardial infarction. He underwent percutaneous coronary intervention with a drug-eluting stent. His new prescription includes aspirin 81 mg once daily, clopidogrel 75 mg once daily, metoprolol tartrate 50 mg twice daily, and atorvastatin 80 mg at night or bedtime. His current medications are tenofovir alafenamide plus emtricitabine and darunavir boosted with cobicistat. So my question to you is, which of the following would be the best approach to minimize adverse outcomes with drug interactions in P.D.M.'s case? Would it be A. Increase the clopidogrel dose to 150 mg once daily, or B. Switch clopidogrel to ticagrelor 90 mg twice daily, or C. Switch atorvastatin to pravastatin 80 mg, or would it be D. Reduce the atorvastatin dose to 20 mg? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Reduce the atorvastatin dose to 20 mg. Protease inhibitors and CoB-C-stat are strong cytochrome P3A4 inhibitors, and atorvastatin 20 mg should not be exceeded when used concomitantly to reduce the risk of myopathy and rhabdomyolysis. That makes answer D correct. Pravastatin concentrations may be increased by boosted darunavir by inhibiting P-glycoprotein. However, pravastatin is a moderate-intensity statin that would not be expected to lower LDL by 50% or more, which is necessary in this patient with atherosclerotic cardiovascular disease. That makes answer C incorrect. Ticagrelor, which is metabolized by CYP3A4, should not be co-administered with PIs because of the risk of bleeding. That makes answer B incorrect. Clopidogrel is converted to its active metabolite principally by CYP2C19. Protease inhibitors like darunavir boosted with CoB-C-stat do not inhibit or induce CYP2C19, therefore, dosage adjustments of clopidogrel are unnecessary, though monitoring is potentially warranted. That makes answer A incorrect. The only ARV drug contraindicated with clopidogrel is etravirine and NNRTI, which is a CYP2C19 inhibitor. Please advance to the next question. And the next question reads, NML, a 45-year-old female patient presents at the HIV clinic for medical care after diagnosis. Her pertinent labs include a CD4 count of 106 cells per millimeter cubed, and a viral load of 182,400 copies per milliliter. She is allergic to sulfur drugs. Dapsone 100 mg daily is initiated for PJP prophylaxis. Her HAART regimen consists of abacavir plus lamivudine plus dolutegravir. Her pertinent labs 30 days later show that her hemoglobin has dropped from 11.5 grams per deciliter to 9.7 grams per deciliter. She denies bleeding or dark stools but admits fatigue. Additional labs are ordered, and the G6-PD is low at 87 units per 1 trillion red blood cells, reticulocyte percent is increased to 5.4%, low haptoglobin less than 6 mg per deciliter, and lactate dehydrogenase LDH concentrations are elevated 717 units per liter. So my question to you is, which of the following is the best explanation for NML's laboratory result changes? Is it A. Hemolytic anemia is an adverse effect of dapsone, or B. Hemolytic anemia is an adverse effect of dolutegravir, or C. Anemia may occur when abacavir is combined with lamivudine, or is it D. Anemia is a common adverse effect of abacavir? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Hemolytic anemia is an adverse effect of dapsone. reduced hemoglobin, increased immature red blood cells, that is reticulocytes, low haptoglobin, and elevated LDH, a characteristic of hemolytic anemia. Antiretroviral therapies do not cause hemolytic anemia, however, zidovudine may cause a macrocytic anemia. That makes answer B incorrect. Abacavir does not cause anemia. That makes answers D and C incorrect. Patients with G6/P.D deficiency are at higher risk of hemolytic anemia with dapsone and should be screened before use. That makes answer A correct. In the United States, the most likely ethnicity with G6/P.D deficiency are African Americans or people with Mediterranean descent. Please move on to the next slide. And the next question reads, GJW, a 38-year-old HIV-positive female patient presents to the hospital, with a chief complaint of 3-week history of non-productive cough, progressive shortness of breath, and wheezing. She reports a persistent fever over the past week, and today, her body temperature is 38.6 degrees Celsius. Her chest X-ray shows bilateral infiltrates with ground glass opacities. GJW presents with hypoxemia with a PaO2 of 66 mm of mercury at room air. She is empirically treated for PJP, and a bronchoalveolar lavage confirms the diagnosis. She has a sulfur allergy and she had a severe rash with sulfur medications the last time a sulfonamide was administered to her. She has a past medical history significant for type 2 diabetes mellitus, and GERD, so my question to you is, which of the regimens listed below would be the best treatment for GJW? Would it be A. Oral dapsone plus IV trimethoprim with IV methylprednisolone, or B. Oral primaquine plus IV clindamycin with IV methylprednisolone, or C. Intravenous pentamidine plus IV methylprednisolone, or would it be D. Aerosolized pentamidine? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Oral primaquine plus IV clindamycin with IV methylprednisolone. This patient's PaO2 less than 70 mm of mercury indicates moderate to severe PJP infection, and she would benefit from adjunctive corticosteroid therapy. The ground glass bilateral infiltrate appearance is characteristic of PJP, as are the progressive onset of pulmonary symptoms over several weeks and non-productive cough. Alternative second-line antibiotics for PJP include clindamycin or primaquine and intravenous pentamidine. That makes answer B correct. Although primaquine must be administered orally, intravenous pentamidine is associated with more toxicities, nephrotoxicity, hyper or hypoglycemia, pancreatitis, and this patient has diabetes. That makes answer C incorrect. The efficacy of aerosolized pentamidine is not comparable with intravenous pentamidine, and aerosolized pentamidine is associated with more relapses. That makes answer D incorrect. Dapsone and trimethoprim are not recommended for use in moderate to severe PJP, which makes answer A incorrect. Please advance to the next question. And the next question reads, CFW, a 64-year-old male patient presents to the hospital, with a chief complaint of a 42-day history of fever, night sweats, and unintentional weight loss. He also describes abdominal pain and diarrhea. On physical examination, hepatosplenomegaly is noted. His pertinent labs include severe anemia. An HIV test shows that he is HIV positive. mycobacterial blood cultures are obtained, and acid-fast bacilli smears show acid-fast bacilli. So my question to you is, which of the following would be the best treatment approach for CFW now? Would it be A. rifabutin plus clarithromycin plus ethambutol, or B. rifabutin plus azithromycin plus ethambutol, or C. ethambutol plus clarithromycin, or would it be D. ethambutol plus azithromycin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. rifabutin plus clarithromycin plus ethambutol. Clarithromycin is the macrolide of choice for disseminated MAC infection. Clarithromycin has been studied more in clinical trials of MAC infection and has more rapid clearance of MAC from blood than azithromycin. That makes answers D and B incorrect. This patient has a newly diagnosed HIV infection and significant immunosuppression, as evidenced by the development of MAC, which is rarely diagnosed with CD4 counts greater than 50 cells per millimeter cubed. Because of his immunosuppression, a third drug is indicated in this patient to improve survival, given that he is currently untreated for HIV infection. That makes answer A correct and answer C incorrect. Please progress to the next question. And the next question reads, KJC, a 47-year-old male patient was seen today at the HIV Comprehensive Care Clinic, abbreviated as CCC, for a routine medical follow-up. According to KJC's medical history, HIV was diagnosed when he was hospitalized for cryptococcal meningitis 10 months ago. He has responded to antifungal treatment with symptom resolution except for residual visual deficits. His pertinent labs imply he is virologically suppressed with CD4 improvements from baseline of 23 cells per millimeter cubed to 108 cells per millimeter cubed 90 days ago and now 132 cells per millimeter cubed. So my question to you is, which of the following would be the best plan for KJC's antifungal therapy? Would it be A. discontinue because of symptom resolution and because CD4 has been greater than 100 cells per millimeter cubed for 3 months or more, or B. continue until he has visual improvement, or C. continue for at least 2 more months, or would it be D. continue for lifelong prophylaxis? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. continue for at least 2 more months. This patient is asymptomatic for signs and symptoms of cryptococcal meningitis. Visual deficits may improve with antifungal therapy for some patients, and others may have permanent loss. That makes answer B incorrect. His immunologic improvement from ART is excellent, and the CD4 count is expected to continue increasing. The full treatment course of cryptococcal meningitis is 1 year of antifungal therapy. That makes answer D incorrect. Fluconazole may be discontinued at that time if the CD4 cell count has been greater than 100 cells per millimeter cubed for at least 3 months in response to antiretroviral therapy. That makes answer A incorrect. Although this patient has met these criteria, he still requires 2 additional months of fluconazole, which makes answer C correct. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it, and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support, and kind collaboration. We look forward to interacting with you in the next video, which will be part 167.